So here now are clinical tests. So Hagit and I developed we looked through the research to find out are there any clinical tests that have been tested and researched to show that they can substitute for some of these radiological tests. So we see on the far right, this T1 to wall distance, which helps to determine how much kyphosis, not just in the thoracic spine, but it often develops in the lumbar spine due to degeneration. And how far forward are they flexing? And you can just do a simple measurement of how far T1 is to the wall on that. Very simple, easy thing to do. And if they are more than 7.5 centimeters, the research shows they are at high risk for pain and disability in the future. So we need to do something in our exercise program that doesn't continue to promote that. We can use a scoliometer to determine, is there a lumbar curve? Because having a lumbar curve puts them more at risk for pain and disability due to the instability in the spine in a thoracolumbar curve. And then finally, you can see Hagit here in the picture to the left using a plumb line to show how far away from the thoracic spine is the pelvis shifted. That's also a risk factor for pain and disability in the future. And we want our exercise program to make sure that we don't make that worse. And if anything, try to realign that.
You know, Lise, some of these, I love these tests because they're so straightforward and, you can see them very obviously. And what I wanted to maybe ask you is just to clarify the idea, you're sort of an expert in this now, with predictor rules. Like, can you explain that a little bit more detail? You did this obviously with Pilates for low back pain as your doctoral thesis. Now we're looking at predictive rules for dysfunction with spine deformities. Explain a little bit about what that means as a predictor rule.
Well, we were able to do a clinical prediction rule in our study on low back pain and Pilates. But using adult spinal deformity in particular it would be very hard to do a clinical prediction rule on, or at least it would take a lot of thought going into it. So what Hagit and I decided to do instead is to take our theory of how can we use radiological parameters to inform these tests that any Pilates instructor can do. And can they be substituted for these radiological criteria? Because the radiological criteria have already determined that those criteria are those that are shared by people who tend to end up getting fusion surgery. So we're just putting it in more of a context or fitness instructors. So we used the Delphi study because this would be a complex study to do a clinical prediction rule on. So instead we decided to ask the experts. And that's what a Delphi study does. It allows you to go, as long as you really define your group of experts, which we did with the PSSE schools around the world, and then get a consensus from them. And if the consensus was over 70%, then we know that they all agree that these clinical tests can be used when radiological criteria are not available.
So it's not necessarily a predictive rule as much as it is just predicting risk factors for them based on the radiological information that we could use.
Yes.
Got it.
Here are some ways of possibly using adult spinal disorder people with adult spinal disorders, and this is a patient of mine who has positive sagittal balance. How do we know that? We did the wall to T1 distance with her. So we're going to avoid doing a lot of forward bending things, and we're going to adapt so that she doesn't continue to collapse in the front. You can see how the collapse of the ribs is onto her pelvis. So we want to open up that space as much as possible for her. And then you can see on the right, she has a lumbar curve with a lumbosacral junctional curve. So she's at some risk for instability in the future. So we're going to avoid doing a lot of side bending with her, even to the other side, because her lumbosacral junctional curve goes the opposite direction of her primary lumbar curve. So we're going to adapt by keeping her elongated, decompressed, and strong in a very stable position of her spine.
You know, Lise, you bring up a really important point that I want to reiterate, and that is a lot of people think when they see coronal plane curves that if you do the exercises like the mermaid or some of the lateral translation ones on the chair and those kind of things, that would improve the curve. But if you're at risk of this instability, any kind of movement like that's going to end up in moving too much in some of these transition joints, and that's where the degeneration takes place and leads to more collapse and more pain in the future. So just reiterating that point that we don't try to necessarily reverse the curve on individuals that are at high risk of instability. So
yes, because if you see the woman sitting down, side bending to the right, she's actually going into her lumbosacral junctional curve, even though it may be reducing her primary lumbar curve. So you have to always understand, just like in a spinal fusion, what happens above and below the primary curve usually has that instability, like you said, those transition areas, Brent.
yeah.
So in this Delphi study, consensus was achieved. So the moral of the study: fitness exercise modification is appropriate when an adult presents with radiological criteria predicting risk for structural spine instability. And number two, that clinical tests, those 3 tests I showed you, can be used when you don't have an X-ray. And 3, that movement competence testing should be done to support modifications of fitness exercises for people with adult spinal disorder. So that being said, that's the end of the presentation. And I'm hoping that with this Delphi study, we can get this published and at least present some guidelines to the fitness community for working with people with adult spinal disorders.